Good afternoon and welcome to the Washington Medical Commission webinar series as part of Patient Safety Awareness Week. Today we have the special opportunity for a roundtable between the Washington Medical Commission and the Nursing Care Quality Assurance Commission on strengthening communication between nurses and physicians. In a moment, I'm going to ask each member of the panel to introduce themselves, but before we begin, I would like to take care of a few housekeeping items. We encourage you to ask questions throughout the discussion, so look for the question chat box on your webinar portal and we'll do our best to address your questions. We are recording this roundtable and the on-demand version will be available on our website within the next few days. So with that out of the way, my name is Jimmy Bush. I am the Director of Quality and Engagement with the Washington State Medical Commission, and I'm going to be your moderator today. So I'm going to pass it off in alphabetical order to Miss Christine Blake to give herself an introduction.
Good afternoon. I'm Christine Blake. I'm a public member of the commission, and my real job, I guess, is I'm Director of Medical Staff Services for the Peace Health System throughout Washington and Oregon and Alaska. So I'm very involved in quality, peer review, credentialing, regulatory compliance. Thanks, Jimmy.
Thanks. Adam, would you like to introduce yourself?
I would. So good afternoon, everyone. I'm Adam Canary. I'm an LPN member of the commission. I also serve as chair of the discipline subcommittee and vice secretary treasurer for the commission as well. And in my other work life, I am a nursing home administrator on Bainbridge Island.
Karen?
Hi, I'm Karen Domino. I'm a professor of anesthesiology and pain medicine at the University of Washington. I've worked a long time at Harborview Medical Center and been practicing at University of Washington Medical Center of Montlake for the past 10 years. I'm a chair-elect of the Washington Medical Commission.
Lindsay?
Hi, I'm Lindsay Marr. I've been a nurse for 10 years. I work at St. Peter Hospital. I'm a bedside nurse, charge nurse, and I'm also a new pro tem member of the NCQAC. So happy to be here with you guys.
Thanks for being here. And Yvonne?
Hi, everyone. My name is Yvonne Strader, and I'm an RN. I have been an RN for well over 30 years. Now you know my age. I mostly worked in acute care. I have a vast history in quality management, risk management, performance improvement, worked at the bedside in pediatrics and in inpatient psych mostly. And I also worked in medical staff services, so worked very, very closely with our medical staff. And I am the current chair of the Washington Nursing Commission. So thanks for having us.
Thank you all for being here today. This is very exciting. I'm glad we get to do this as part of Patient Safety Awareness Week. And just to kind of jump right into our questions, I think we can all agree that a high functioning team is essential to positive patient outcomes. But I would like to start this discussion by asking you to share any insights or data you may have about how teamwork affects patient safety. And to start us off, I'm going to pass it over to Karen.
Hi, I've done a lot of work in my research in patient safety in the perioperative area, critical care, and pain medicine. One thing I can tell you overall is that the Joint Commission has put communication, and that's just a broad category of communication, as a number 3 most common issue, a root cause of any sentinel event that occurs in the hospital. And those in my area, in a surgical area, it's number 1 as the cause. Also, you know, going through time, and I'm also older as well, the surgical checklist has, I think, made a big impact on formalizing communication during surgery, in preparing for surgery and certain procedures. And it's used around the world, and it's been shown to reduce mortality and morbidity in surgical patients. What it does is it gets the entire team, that includes the anesthesia team, the surgical team, the nurses, the techs, and everyone on board over potential problems that may arise during the surgery, such as a difficult intubation, a possible risk of an operating room fire with the use of oxygen and electrocautery, and hemorrhage, and that's important as well. And also there's literature in the critical care area in particular that says effective leadership and teamwork is so important, and particularly it's one of creating a safe environment where all team members of all disciplines are able to have a discussion, since each of us only deals with a certain piece of the patient. And you know, we also see from the commission that rude, arrogant, obnoxious physician language in dealing with patients and with nurses is a big issue. And it makes, I mean, if someone yells at me, I want to withdraw, right? I don't want to do anything. I don't want to talk to them at all. And so there's a problem then, in that there may be a delay in nurses who pick up the problems that arise. They're the ones on the scene doing it, in not wanting to talk to someone who is obnoxious and intimidating and disrespectful.
Jimmy, do you want us just to weigh in and just
Jump
have
in.
kind of a
Jump
free-for-all conversation?
Yeah,
okay.
let's do it.
Well, I can't agree with you more. And you know, it respect for the human being in front of you, whether it's the patient, whether it's the caregiver, whether it's the nurse, the housekeeper, whatever. They're all actually taken care of or part of the care of the patient. And so I think that respect is absolutely key in parking your ego at the door. And that's for everyone. There's hierarchy from physician to nurse. There's hierarchy in nurse to nurse. It depends on what unit you're working on. I've seen breakdowns in communication and respect, especially within titles, you know, within the hierarchy in medical care, especially in acute care, which I haven't had the opportunity to work in long-term care much. But it really, that break in relationship and that disrespect for the other person really cuts off that communication path. And you're not willing to listen to that patient or to that person. And that person might have some really vital information that you need in order to take care of the patient or to relay information to the next caregiver. So absolutely agree with what Dr. Domino has said.
Any other thoughts?
I was just gonna say that I agree with both those things, and also like it's about the whole treatment team. I work obviously in a hospital acute care setting, but I mean, like if you can get the provider, the physical therapist, the whole team, treatment team, about a patient together and have good communication, the patient's outcomes are better, their experience is better. I don't have any data, but I can see like when everybody communicates very efficiently on a patient, it is a lot better for the patient than people coming and doing their piece of the puzzle, and where nurses at the bedside are trying to figure out what the doctor came in and decided for the patient, or what the physical therapist decides their mobility is. It's really great to have everybody on the same page, because the patient is always the focus, and what's best for the patient is everybody to communicate well together.
And I just wanted to add one thing. I was, and this is a data point that I often talk about with my team, but NIH did a study in 2013, and they found that after implementing a patient-centered medical approach, that higher functioning teams was associated with a lower mortality in 4% of the patients they looked at, which I think is significant. I mean, just how well we can deal with each other impacts that large of a number of patients with just mortality. So.
So my next question is, how does trust and communication between a nurse and a physician affect patient safety? Adam kind of gave us a statistic, but I'm going to pass this over to Yvonne first to get the conversation going, but just kind of discussing that trust and communication aspect.
Well, as I mentioned before, trust has a profound impact on patient safety, and it just doesn't come automatically. You don't walk on a unit, you don't walk into a patient room, you don't walk into an OR or a pre-op area and just automatically trust is there between the caregivers. It has to be built, and it has to be earned on both sides of the aisle, if so to speak. So, and again, you put your ego at the door, you introduce yourself to each other, and you seek to understand what the other person wants to relay to you. So it takes intentionality. You can't assume it as soon as you walk onto the unit, as soon as you walk in and meet somebody. It's not there. It's all about building a relationship, and that's all about respect and listening to the person and listening to them, seeking to understand what they're having to say, not just hearing them, but actually listening and giving them positive feedback that, you know, you're interested in what they have to say. Physicians are not going to trust a nurse who constantly calls them, and I mean constantly. Could be 1 or 2 times that, you know, they called in the middle of the night, but sometimes that's, you know, they think that that's constantly. But if you call a physician in the middle of the night, or even in the middle of the day when they're with other patients in their office, and you hem and haw or hint and hope or don't get that message across in a succinct and informative manner, they're not going to trust you next time they say, "Oh, Yvonne's on the phone, she really needs your help." But if I give that physician enough information, this is what's going on with my patient, this is what's changed, this is why I'm concerned, this is what I need, they're more apt to give you the information quickly, and that way they can get back to the other patient, because who's the most important patient? The one that's right smack dab in front of you. So you have to start with building the trust, and that is with everybody that's going to take care of that patient, including the patient, definitely including the patient.
And I'll just echo Yvonne. The American Healthcare Association, as well as Duke and a plethora of other places, have done a ton of research on this. But when there's trust, obviously the communication improves, which ultimately leads to more effective collaboration. And when our efficiency levels raise, healthcare teams can improve patient outcomes, prevent medical errors, and improve efficiency and increase patient satisfaction. So, I mean, it's a profound impact trust and improved communication can have on the team.
And I'll just say, working in a teaching hospital, we're training a lot of our physicians, residents in all areas to be able to have these good communication skills. I mean, SBAR is an example of what the situation, the background, the assessment, and those things, so that the communication is more formalized. Just like Yvonne was saying, that kind of communication is something that gets to the point efficiently and gives people enough information to have an effective communication and make a decision.
So can you explain or maybe give an example or two of a reason or source of physician-nurse communication conflict and maybe where that communication breaks down? Christine, you want to start us off?
Sure. When I was asked about this, I thought, okay, where am I going to pull from? I'm going to pull from real time since I'm still working in facilities and see and hear a lot of this. A lot of issues come through what we call safe to share, the variance reports. Reports can get put in by nursing or other members of the team, and a lot of what I see is a lot of what we've just been talking about. I think we're all singing the same song off the same sheet, but there were okay, so some of the things that I jotted down were the perceived lack of respect from physicians, that being interrupted before the nurse was finished, they're in a hurry, there's all this burnout happening, the communication is not thorough. There's frustration then, provider hangs up, nurse is afraid to call back and say what I really need is. So then a barrier, there's a barrier, and then sometimes that continues to exist between that particular provider and that nurse because it brought this culture around with those two people, and it causes a lot of conflict in that way. Also, there sometimes are language barriers and with providers culturally, and that sometimes has become a problem. And some are, as you said, Yvonne, nurses being prepared to, when you call a physician in the middle of the night or whenever, and you say you need them, to be succinct, what do you need? Some of them felt uncomfortable about what to report to the physician because they might be hurried along, or I knew that, or can you give me something new here? Or so I think that there's a lot of that breakdown to that, and I do attribute it, some of it to burnout and some of it to maybe culturally. Some providers have, it's just been this way, which it shouldn't be. And talking about the collaboration between teams, our critical care department in one of our facilities has actually gone back to that rounding team, treatment team, where everybody that's involved with that patient is there to round on that patient, PT, pharmacy, nursing, handoffs, all of that. And they're finding that to be extremely valuable to bring that back in again. So that I agree is a great way to have communication, and everybody just stopping and listening when that person is speaking, whoever that might be, the pharmacy, the tech, the EBS with what issues they have. I mean, it goes all the way down to everyone that is going to be in that room taking care of that patient.
I think there are a lot of things that influence the conflict that don't necessarily aren't the blame of any one person, but like Christine said, time constraints, inadequate staffing, lack of resources. I think a lot of unnecessary documentation that needs to be done on everyone's part takes a lot of time to take care of that patient and to complete. And it's something that we just don't have in a 8 to 12 hour shift to get all the work done. And I think that weighs heavily on the caregivers. I think the workload that we have is in all care settings. I don't care what care setting you're at. it still influences. And to take that little bit of time, Christine, like you were saying, and rounding on the patient, it doesn't take that long to gather really good information from each other if everyone is there at the same time. If you invest some of that time, I think it really pays off in the end.
It does, and you're right, Yvonne, all that extra documentation, Epic, all the things that, you know, if a provider leaves and they don't put a note in and the nurse can't move forward because the doctor has to put it in. And then there's all of that, you know, all of that issue that happens, which causes, you know, raised blood pressures. So yeah, there's a lot.
I just want to say one of the other things I think that's different after COVID too, besides this extreme pressure on all of us for productivity, is you know, we have a lot of traveling nurses who come and spend a brief period of time in the institution. That also includes techs as well, and they may not you know the procedures or the individuals, and so it can contribute to some frustrations perhaps that wouldn't have arisen without the production pressure and having a whole number of people who change every 3 months or so. So that's a whole different thing that's made it challenging in hospitals now.
And as you can tell, I'm a numbers kind of guy. So I was reading this quote, and it was from an anonymous person, but it said 80% of your success is linked with your ability to deal with people. And I thought that was kind of low. So I started doing some research, and I stumbled on this number that people holding healthcare leadership positions routinely deal with, in a recent study, anywhere from 30 to 40% of workplace conflict. And one of the questions I always ask people is, can you imagine if you had 30% more of your time to spend, you know, with the patient at bedside or education? I mean, the outcomes alone would be staggering. So.
So I've recently read a few papers that talk about the communication, not conflict, but an issue between physician-nurse communication results from almost a feeling of intimidation between from the nurse, and how this power differential is affecting the relationship and ultimately the patient. So, Lindsay, I'm wondering if you would share a situation where you've experienced or witnessed this power differential.
Well, I was thinking about this question before, and I mean, I've witnessed providers yelling at nurses before, but I feel like the biggest issue that resulting from communication and some sort of a power differential is mostly like instances that occur over and over again with a specific provider. So it's not necessarily a dramatic event that I'm witnessing, but it's more like nurses not feeling comfortable reaching out to providers because they don't think that they're going to get an answer, or they think that they're going to get blown off, or that the tone between the provider and the nurse feels belittling to the nurse. And the biggest issue with that is if it happens over and over, nurses feel less they are worried about reaching out to the provider. They will, because that's our job to advocate for our patients and everything, but they feel intimidated, and then the communication gets worse because they're already on edge because they know that they're going to speak to a provider that might probably not listen to them. And then their SBAR kind of goes out the window, or, you know, there's some providers that I work with where I know, okay, this is a provider that needs me to say something like quick, to the point, and I'll write it down and I'll do that. But, you know, like a newer nurse might be like, I'm not going to page them. So that's where I think that, you know, as a charge nurse and a leader on my unit, I will step in and say, I will do that for you if you feel uncomfortable. But it's like a pattern of a tone different that makes nurses feel maybe belittled or less than the provider. And I think that's the biggest thing that I've seen that can actually cause a real issue with patient care. So not a dramatic event that I've witnessed, but it's still like a pattern, and I think it's important to note. So thank you.
Jimmy, can I ask a question of Lindsay then? So do you think it's felt out there by nursing and for the team that's on here? Well, we're not going to bother to say anything because nothing's going to get done anyway. I mean, like, this provider is that's who he is kind of a thing, or do you feel that, you know, there's support within your team from med staff leadership, say?
I think that you hit that smack dab on the head, that it comes from leadership on down. My last position that I retired from was a chief nursing officer. And if you had to model that behavior, you had to follow through on bad behaviors, no matter where they came from. But if it was a physician to a nurse, then you dealt with that. And if you didn't, then you have that attitude of nothing's ever going to change. Why should I write this up? Why should I behave any differently? Because it's never going to change. Leadership, it starts at leadership, starts right from the top. So that's a really good point, Christine.
Well, let me just say that you know, over time there's been a big change in that hospitals are taking action against what we would call the quote disruptive physician, who often is intimidating, belligerent, rude, and nasty, and that's different. It's written into all of our hospital privileges now that we have to be respectful to everybody, and if you start failing to do that, you can be removed. And it's happened. The other thing is, I say from the medical commission, we take that seriously as well, you know, because we find that physicians, if a nurse makes a complaint because the physician yells at them in the middle of the night when there's some change in a patient and slams down the phone, and that impairs patient safety. So it is something we do consider and discipline physicians for that. It's hard to make them change, I think, but at least they can learn about some of the adverse effects and maybe from a cerebral end of thinking help control and moderate some of their emotional behavior.
I think that we're also educating nurses and other caregivers on that, as well as how to respond to those situations. There's tools like DESK, you know, that you describe the action, you know, how does it make you feel? And you sit down with that provider after you cool off or after they cool off, but you come back and you're responsible to have that conversation with the person that really talked down to you. And it's pretty powerful if the nurse can actually do that. I worked for Providence, and we did teach this, and we taught it to students as well.
I just wanted to add that, you know, I think in talking about power differential, it leads teams to kind of view the dynamics of power differently than those who don't look at it as a true differential. And I think the teams that look at it as there's a differential view power as a finite amount available to get things done and make things happen according to their own agenda. So then it becomes a resource that people compete for or try to take with force or charisma or charm, and it doesn't always lead to the best outcomes. And the example I was kind of thinking of is I've worked with MDs and RNs who get along and look at each other as equal members with a C, and innately they'll rely more so on the expertise, and then it becomes a force of good, and they build positive relationships, not just between themselves, but with the patients. And it really does foster a sense of trust with coworkers and other people.
So kind of continuing this conversation of, this charge really kind of has to come from leadership. I'm wondering if we could talk more about how workplace culture and that leadership plays into the MD-RN relationship, and any advice you might have for our audience about how to shift that culture, maybe encourage your leadership to take a little stronger action. Lindsay, do you have any advice?
Yeah, I wanted to do the next question too, because I don't always I have really good experiences with providers too, and I work on a inpatient unit, surgical and a medical floor, and the culture is definitely different. Our surgeons will, the relationship between the nurses and the surgeons that we work with is really good. Oftentimes, we'll walk into a patient room with them. We'll know the plan of care. We know what they like for their surgical patients, what they don't like. Our relationship is really strong in that way, and the rapport is there because they're on the unit rounding on the patients. That's where they go. They're here to see all of the orthopedic patients on that floor or whatever surgery it is. And so we get to know them really well. They get to know us really well. And because of the rapport that we have, the culture is different. And I really enjoy those providers. The trust is there. The communication is there. They trust me. I trust them. And that works really well. And then we also take care of medical patients as well, which include hospitalists, and they go throughout the whole hospital. So we don't see them as much. They may have a few patients on our floor and then patients scattered throughout the tower. And then you don't really know the provider as well. Still, most of the providers I work with are great, and there's only a handful that I know what they need from me to make it an effective communication exchange. But I don't know I can't really explain what I guess the difference in the culture between the hospitalists and like a surgeon type thing is just that I see them more. We know each other better, and the communication and trust is really strong with that. So I don't know. I don't know how to change that for all providers, or I think obviously the longer you're at a hospital, the more kind of respect and relationship you have with a provider. So if I've been at my organization for 10 years, I know almost every hospitalist, and so we have a good. I know their communication needs. They trust me most of the time, and so I don't know what the difference is, but I think that there can be a really good relationship with providers and nurses, and those patients that I take care of, the surgical patients, they know the plan. They know what they need to do to get discharged. They know that I'm going to contact the surgeon, and if anything happens, and they know they'll get follow through. And so that's really important.
We have a question from the audience that kind of fits in this vein, and ask the question a little bit differently, but I think it's important to let everyone know. So for anyone who would like to speak up, what do you recommend for physicians and nurses who work in an environment where leadership is not supporting their efforts to affect positive change? How can docs and nurses compensate for poor leadership?
I think that's a great question. And I work in what's considered a small nursing home, and so that there's goods and bads with working in smaller ones, but I think one of the best ones is interacting with all the staff members, from frontline staff to the medical director, and being able to build those authentic relationships. And one of the best quotes that I use a lot is in the definition of what actually culture is. And I paraphrase it and say, hey, it's our personality of our organization, and it's the sum of its values, traditions, beliefs, interactions, behaviors, and attitudes. And titles aren't necessary to drive that personality. You know, if you want better interactions and better behaviors and attitudes, we have to look internally and ask ourselves, what are we doing to contribute to that? Are we talking about it? Are we giving up and, you know, saying, hey, leadership doesn't want to do it? Are we following the pathway to bring those discussions up and hold people accountable, and really create that personality for our organization? And I think regardless of title, every person of the team can impact that. So.
Adam, I can piggyback on that with what we've done in this institution, and that is the medical staff leadership team, which would be our chief of staff, vice chief, chair of that particular department. When there's a concern that's brought up by nursing, the provider is made aware of it, and there's a conversation with them about what occurred, obviously listening to both sides of the story, right? Giving everybody an opportunity to speak about what occurred, having and asking, like you said, that physician or caregiver, whether it's allied or whatever the provider is, to take a look at their part in what occurred and what had caused that, what led up to that blow up or whatever, or lack of communication or inappropriate behavior. And for the nursing side, obviously, that's not the piece that we're involved in on that side, but many times I'm going to say that it did help to bring a few providers around. Some of them ended up having to go to some disciplinary route. If you have to take that route, then you have to take it. But a lot of them took it to heart and actually listened and were appreciative that we brought them in to tell them about it. And we've watched a bit of a change in some of them. And those that are very difficult, like Karen said, if they're reported or it gets up to that level, then that's taken seriously by the commission as well, and also by med staff leadership. So when you mentioned leadership on down, whoever had the question, I'm not sure if you mean administratively or just from the med staff leadership side, but that is a way that it's been handled and has had some success, although, like I said, not everybody wants to listen to that or take a look at themselves. So.
Yeah, and I'm not exactly sure where that exactly what level, you know, isn't following through, but there are a lot of avenues. And my advice to the person that asked the question is don't give up, you know, because the patient is ultimately, patient's outcome is what we all want the best for. And we all have shortcomings, and we all have blind sides that we don't even know, how we're acting or that we're not acting. But there are other avenues if you just run out. There's integrity lines. There's both nursing commission and medical commission that you can report to. There's also, I hate to say it, but there's joint commission. There's, Department of Health. If you feel that it's really impacting patient care and patient outcomes, then you have a responsibility to just don't give up. Just keep advocating for yourself. You got to find that person that will stand with you and walk by your side and get it right.
So Adam, as my statistics and data guy, I'm wondering if you have any strategies or research on that our audience could implement to improve the MD-RN relationship, maybe specifically at your workplace or something you've learned in the past?
This is the one where I didn't have a ton of data, kind of just more of a gut feeling, what's worked for me, what hasn't worked. And one of the things I lean into is we have to be able to control what we can control, and the first strategy is to take responsibility. I think sometimes we become our biggest barriers or hurdles. It's just our ego or our ideas. But if we're all striving for the same thing, great patient outcomes, staff satisfaction, we have to look internally and take responsibility. If we're noticing a particular pattern, I think the easiest question is to take a step back and ask ourselves, is there a specific way I'm doing something that may be getting lost in translation? But looking internally sets an example for everyone else to follow, and it also keeps any feedback you might have respected and credible. And the second strategy is to practice mindfulness. It helps to lower stress levels. It helps to keep you grounded. But I think it's important not to dwell on the past interactions or worrying about, how it might impact you in the future, but staying clear-headed and focused on the goals of your patient's outcomes, I think is vital to it. So I would say my two strategies to recommend is mindfulness and self-discipline with responsibility.
I was just going to say that, we've had a lot of instruction as well. Again, coming from a university, it's sort of normal, but there is team steps that I was done quite a long time ago on both, I think, in the emergency room and on the obstetric unit, that really helped reduce, really improve both relationships and I think quality of care. And so that's a formal program. We in anesthesia had to go through at least some elements of this, and some were incorporated into our perioperative discussions with the team members. So there are that. There are also, simulation in my specialty is used a lot of, not necessarily in Washington State, but also that gives you crew resource management skills. And we model after the airline industry and a lot of things to really, in terms of different type of language skills and how do you approach, a situation where you wish to escalate beyond when you feel someone's not listening to you and you have concerns. And so I think those kind of teaching of team behavior, team interaction, and how to best phrase things to have a effective communication is useful as well.
There are so many good tools and programs out there that we teach. I know Providence used them, IHI, and with the culture of safety. And so everyone, you have to invest in all of your employers and all your leaders to go through a set of courses. And like Dr. Delmana said, you know, you teach everyone what the expectations are, and then you teach them how to use the tools, what the tools are, how to use the tools. Leaders had special training, and they actually were expected to teach the classes. So kind of ingrained in you those tools and those messages, those expectations of how to behave and how better to communicate. And I'm sure, Lindsay, that you've gone through the same training, right?
I didn't hear that last part.
Just the safety training, the culture of safety training, and yeah, you know, safety huddles. We have safety huddles every day. I think that every hospital has safety huddles every day where you have debriefing of falls or events that happen, and you dissect them and you figure out what causative factors are. And a lot of it is communication and culture.
Say another strategy that we've had in recent years is one where, besides that training, if you have someone who doesn't follow the quote rules, they get reported. and there's actually a whole, we have someone in charge of professionalism. And I can use an example of, in the radiology department, there was a huge outburst by a physician and went after a whole pile of people. And it was totally inappropriate. And he said things to the patient that were inappropriate as well. Well, these, you know, lots of people heard this, and this was reported and went to the professionalism committee. I mean, it's a big center and the person in charge of professionalism in the hospital, and things, I think, you know, they had discussions with everyone, and I don't think this kind of outburst will ever happen again by the individual, because that individual could lose their privileges. And they also, people, you know, in a university where you are, while we have some people who only do clinical care, they're still on a clinical track, and there's certain period of time you have to be able to get promoted, not necessarily in the clinical track completely, but that lack of negative interactions do, unfortunately, for individuals, affect their ability to be promoted. Big thing in a university setting, different than in a community hospital. But those are the reports you can use everywhere, right? And sometimes people don't even appreciate that they had an issue, or maybe they you know, lost control, and they can kind of reflect back about, well, what was it that pushed my buttons, and how can I prevent losing control in the future?
Yeah, I agree, Karen. We do like a little mini RCA dissection if there's been a massive outburst of where did that start and how did it end up that way. I think that there should probably be a class for providers before they hit boots on the ground in a hospital to talk about, you know, teamwork, collaboration, all of those things. There isn't that. They just walk into a hospital, graduate, and here I am, your new doctor. And
I think there's more now with people and residencies and also in medical school about this, as some of the data has come through about impact on patient safety. So I don't know. Of course, those are young people, and you have a lot of, you know, people
Correct.
who've been trained 30, 35
Yes.
years ago, 20 years ago, or 10 years ago, or maybe they came from another country, which is a whole nother thing, since
Exactly.
they're not used to the US culture. And a lot of those people often have a doctor knows best mentality, which it is a far stronger way than it is in the United States.
That's
So,
true.
yeah. but it is useful. I mean, we, just so you know, like we rank one of the questions that we have a daily ranking of our residents in terms of their how they did in cases and how you're working with or on your team in ICU, and showing respect for everybody is on that list. That is it. And we've had people, if they have a problem to begin with, many of these folks are now weeded out of training. Unlike the old days when I went to med school, when, you know, it was really grades and, you know, expertise and that scientific expertise. Now I think it's recognized that communication skills are extremely important. So it will be a long time before change, but
Yeah,
I'm optimistic, you know.
it might be worth bringing it to the hospital level with the onboarding process with providers as well, so that there's an understanding of the culture of the facility and what is acceptable and what is not. Because we all know that you send doctors 25 documents, bylaws, policies, they're not going to read them all. So might be worth putting into an onboarding system.
So Christine, at my last hospital, we did that. We had an onboarding, and the new physicians met with a myriad of different folks in patient safety, communication, principals partnership. I think what Karen was alluding to before, with, you know, behavior expectations when they first come on board, and then the ramifications of what happens if you don't uphold the code of conduct. But I think that really helped, especially the brand new hospitalists and brand new ED physicians coming on board.
Yeah, a lot of that fell by the wayside when you had to do virtual onboarding with COVID. So it'd be great to bring that back.
Yeah.
So as we kind of come to the end of our time together, I want to let the audience know we do have time for maybe one or two questions. And while you're typing those up, we did get a question earlier that asks, how do you recommend approaching a situation where someone has not followed an order properly? Would you communicate with the nurse directly, go to the nurse supervisor? What advice would you have for addressing that situation?
I would say going to the nurse directly and possibly the charge nurse as well, because the charge nurse can always follow up with that nurse at another time too.
Yeah, I was going to suggest you start with the individual. I mean, there may be a reason, and then if, you know, depending on the response, perhaps escalate it, or whether it's a repeated problem. We all make mistakes, right? So you have to give someone a break. Say if they had 40 patients and things, you know, something happened and they were feeling sick that day. I don't know. So that's why I start with the individual, I think.
And when you approach that individual, do it in a non-public setting, in a private setting where you can have a respectful conversation with them. And, you know, that's a lot less threatening. You can get a lot more done that way.
You know, I'll add to it, because I've had this happen in my setting, and I think it's the role we want to play. If it's a one-off, I think going straight to them, but coming from a place of wanting to help them grow or learn, you know, what they didn't follow or how they didn't follow it, or what you would like to see going forward. And then I also think maybe looping in leadership if it becomes a trend, so it becomes a more of a collaborative approach to improve all systems, but then it becomes a team effort to do it and not as punitive.
Well, I hope our audience will join me in a virtual round of applause. Thank you so much, everyone, for this discussion. It has been amazing, and I really appreciate everyone being here. Thank you to everyone for attending and participating. And I just want to say have a wonderful week and remember to take care of yourselves. Thank you.
Thank you.
Thank you.